Welcome back to the Arthritis Broadcast Network, coming to you from sunny Victoria this afternoon, believe it or not. And my name is Kelly English. I'm from the Arthritis Patient Advisory Board of Arthritis Research Canada. And I welcome you, Ross Duncan. You are Mark Harrison's trainee, or
Yes.
were Mark Harrison's trainee,
Mm-hmm.
working on what project, if you don't mind me asking?
So what we were working on is essentially an introduction of nursing support to rheumatology care in British Columbia, which hadn't existed prior to 2011. And the idea behind that was a growing concern among rheumatologists themselves in British Columbia that there wasn't effectively sufficient coverage to provide continuing access to care. So one response to that, rather than trying to bring in rheumatologists from other places or train a new generation, which would take quite some time, there was an existing body of people who had experience doing counseling work and patient education and patient assessment, and those people are nurses. So the idea was that if we can bring nurses into the rheumatology community, into the clinic, it would allow them to take on some of the role that rheumatologists were performing. So
Perfect. I know in the rheumatology world, we've been very concerned about losing a lot of our rheumatologists.
Yes, unfortunately, it did look like that was going to happen.
Yes, and I noticed that also our access is a little better. Have you noticed that? Have you shown a bit of an improvement?
I'm happy to hear that you've noticed that there's been a bit of an improvement in access because as we've sort of finalized our research on looking at access, so notably the number of patients being seen and the number of services provided, what we do see is that you do get a boost from bringing a nurse into the rheumatology clinic. It's not clear whether or not that actually leads to an ongoing increasing improvement over time in the number of people you can see, but certainly it gives you a good, solid one-time boost to capacity.
Which we needed.
Which is definitely a good thing.
That's a good thing,
yes.
Absolutely. And can you tell me, are you working through a ministry for this, or were you working through UBC, or?
So I was working primarily with Dr. Harrison at UBC in the Faculty of Pharmaceutical Sciences, but one of the things about rheumatology care in these projects in general is we've been working with a whole bunch of people. So it's a CIHR funded grant, but we have support from the Ministry of Health, we have support from the Arthritis Society and other groups that are interested in basically making sure that this work is done. Not just in sort of an academic setting, but in a more policy and patient-oriented setting as well.
So are you sort of leaning towards the policy?
That's my area of interest, yes.
Okay.
It is essentially health policy and how we can make changes on a policy side to provide better care for British Columbians.
We need that. We need that, always, because if we can balance out that policy and the money, we can keep those rheumatologists working, basically, and the patient's happy.
That's what we're hoping.
From a
that's
patient.
what we're hoping for. Yeah.
So, have you been able to see some of the meetings so far?
Unfortunately, not. I've just flown in. So this is, I think, one of the questions was, what's the most exciting thing that's happened? This is definitely it.
This is it.
Yeah.
Well, hey, we're always the most exciting.
But it's as you said, it's a lovely sunny day. It's a beautiful hotel, and it's nice to be here.
Good.
Yeah.
Good. And this year's theme is 2020 vision, and I think that that's something that that we all have to have a bit different vision of what our future is going to be. Have you guys given some thought as to how you can maintain the momentum that you've started?
I think one of the encouraging things that I've seen both as a master's student, and I'm a relative rheumatology novice, I should say. I don't have lived experience with it. I'm not a clinician. But there seems to be an emphasis on listening to different people and hearing what they say and then incorporating that into both decision making and the way that research is done. And that seems to be probably one of the most fruitful ways forward, is rather than the government or researchers determining what is important and going out and doing that on their own without consulting patients or the public. By being able to actually ask people what's important to your life, to your lived experience, how can you be better supported? That creates all sorts of avenues that may not have otherwise occurred to us on the research end or on the policy end. And that's kind of where I see things increasingly moving forward, is a sort of dialogue between patients, providers, and I guess policymakers.
We like to hear that, because as patients we like to be engaged, and we do have something to offer. it's hard to make a policy without knowing what people are going through, I think, sometimes.
Mm-hmm.
So, has there been a really frustrating or a really high moment of what you've done so far?
Ooh, I suppose you always want to kind of know more about certain things. I've been working with administrative data, which is a bit it's kind of tricky because it's not really built to answer research questions. It's built to show who showed up at the office at what time. So
exactly.
One of the most frustrating things is trying to figure out, okay, how can we turn that into something intelligible? And that's why it's also helpful to be working with sort of a broad multidisciplinary team so they can point those things out to you. I think what's going to be exciting is some work that Dr. Harrison and one of his postdoc students, Magda Aguiar, are working on, which is the qualitative portion.
Okay.
So I sat down and crunched numbers, but what they're going to do is actually go out and talk to rheumatologists and nurses and patients and say, how's this going? What's happening on the ground? And by combining that with the numbers, I think we get a much better sense of what is actually happening and being able to interpret that and hopefully make some further improvements.
And how many rheumatologists did you get on board for this part of it that you were involved with?
Oh, for the part that we were involved with? Well, unfortunately for the rheumatologists, they don't get much of a say because if they're billing in MSP, I can see them. They're all anonymized, so
okay.
I don't know if I'm going to be able to point out anybody by name and say,
no,
you
used
a nurse
okay.
this many times. No. That's not the point. But I think there was something like 57 practicing in the province over the study. And of those, I think, over the study period we were looking at, which was from 2009 to 2016, something like 27 of them used a nurse.
Excellent.
At some point. Yeah.
Excellent. And do you see that funding continuing?
Well, I'm hoping.
Was there extra Was there extra funding?
Yeah, so the funding situation, I'm not sure. I think the BC Society of Rheumatologists is probably in negotiations with Ministry about that. I know this is about the time that it was up for review because it was one of those initiatives that it wasn't a specific line item in the budget. It was one of those things where for the ministry, if they want to try experimental or basically special projects, and this is how the nursing support was funded. But I'm hoping that will continue because I think we can demonstrate that it improves access to care. And Dr. Harrison and some other researchers are going to continue to looking into things like medication adherence and quality of care and patient satisfaction with nursing support. And I'm hoping that there'll be evidence there to support the continuation of the program.
And where does your training go on to? What are you aiming for? I believe you said you were working on your master's. Was that correct?
So I was working on my master's with Dr. Harrison. I finished that up. I suppose I graduated in November. I've kind of stuck around in the policy space. So I'm now working at the BC Academic Health Sciences Network, which is an umbrella organization that helps run things like the BC Support Unit, patient-oriented research, strategies for patient-oriented research, and Research Ethics BC. So I've kind of kicked myself upstairs a little bit, going at a slightly higher level. But I think it's a very interesting sort of pathway as we move forward, and I'm glad to still be involved, even if it is a little off to one side.
Well, it sounds like from what I talked to you about earlier, we'd like to have you aboard.
Thank you very much.
Any questions, Anita?
Yes. Does having nurses in the room clinic achieve shorter initial wait times and achieve earlier diagnosis?
Our data doesn't directly suggest that, but I can say anecdotally from having spoken to some rheumatologists, especially if they use multiple nurses, that it can do. You can really much increase your patient volume. I'm not entirely sure how many times you're in a waiting room in a community clinic setting, because I think most of the time you're making appointments. But certainly you should be able to see more patients more quickly, in theory.
We'd like to hear that.
Yeah.
Thank you very much for coming with us, Dr. Duncan.
All right.
Oh, pardon me, Ross Duncan.
That's
and
all right,
next
I'll
time
take
I
it.
see you,
Yeah.
maybe there will be a doctor
Yeah,
in
maybe.
front of that.
Right.
I know you're going towards it.
Okay. Thank you, Kelly.
Congratulations.